What?
And what? Hi,
Okay.
guys. Thanks for joining. This is Essence of Medicine. Today, we're going to be doing a live clinical case review. My name is Amanda Armagast.
And I'm Dr. Abbasi for Essence. And today we are going to talk about not a common problem in the brain and the rest of the body, but nevertheless something that has been mysterious for a long time. It is just in the last 200 years that we understand the complexity of our body, how different parts work with each other. And everything until just recently was mysterious, and we had no way of knowing what's going on because we couldn't look inside. The only way we could look inside of somebody was opening them up with a surgery. And obviously, and that is just in the last 100 years that we can do that safely. So practically until 100 years ago, we have this patient with different kind of symptoms, with the patient who presented in certain way. And after the Renaissance, by this idea of scientific observation, scientific method, we noticed that certain symptoms or certain findings in a patient lead to certain symptoms and then certain disease and certain outcome. This clinical observation was actually mastered in France and then in Germany. For that reason, lots of anatomical, pathological, and disease names are actually German. And what I'm going to present you is actually one of them. That we knew that it exists for a long time, but just in the last, I would say probably 70 years or 50 years, we truly have a good understanding how it come to be. But the unbelievable part is that we still don't know exactly what it is. Well, I think more with the genetic methods and tools we have, I think we are at the verge of truly understanding it. I'm just going to present actually the actual patient now here. Okay. Nope, that is not the one I wanted to present. Let me bring the one that I wanted to present to here it is. So these are a group of people that are younger, but this specific patient was 45 years old and had just history of seizure, common on now the recent onset of seizure, generalized seizure, no other pre-medical history, no allergies. Patient obviously have been put on some seizure control medication, and the neuro exam surprisingly is intact. Now, recent onset of seizure, Amanda, you are not in medical field, but usually we start being concerned about certain things, and the major thing in a case like that is intracranial tumors, especially if somebody is 45 years old. In that age group, when somebody has seizure, the first thing we are concerned about is actually intracranial tumor, like brain tumor. They're obviously not a good thing to have, but we get a CT. That is bleeding tumor. These are the major reasons. So in the emergency room, obviously, a CT is faster to get. And this is the patient's CT. That, again, you are not in medical field, but what I, as neurosurgeon, would see here is that the ventricles are not large. I don't see any midline shift, meaning the brain is not, one part of the brain is not pushing toward the other side. That would be midline shift. That is usually a sign that something growing inside of the brain, that something could be a tumor, could be bleeding, could be enlarged chamber, fluid chamber inside of the brain. None of that is happening. But I think what's interesting is when we come up, higher up, we see that in the midline, in the middle of the brain, that this structure that is part of the rough membrane around the dura, around the brain, we call that dura, is thickening. And this part is actually called falx. Falx is a part of the membrane over the brain that separate two hemispheres of the brain. And that is what we see here. And obviously then the question is, what are the typical pathologies that makes the falx or the part of the membrane that surround our brain to grow? There are some benign tumors there, like meningioma. There are obviously bleeding in that location can cause that. But the bleeding, yeah, we can measure it in CT by actually measuring how dense the material is there. This does not seem to be bleeding. And as well, bleeding has like other characteristic that makes us believe that this is not the bleeding, but it's something inside of the membrane that growing. That something obviously can be meningioma, can be some other tumors. As a matter of fact, some cancers of the blood, they can appear on the CT in the brain like that, like lymphomas and so on. Some other childhood tumors can as well appear that way, and some childhood autoimmune disease can appear like that. But this patient is 45 years old, so that is not common in adult now. And the question is, what is this? What's growing? Obviously, we do have our differential diagnosis, but at the end of the day, a finding like that, based on the rarity and the wide potential of being something that we may be able to treat or not, requires us to take a piece of it and examine it under the microscope. So this finding is actually in the middle of the brain, in the midline. Practically we decided to go and take a piece of it out, do a biopsy, and examine it under the microscope. So there's a problem there, because in the middle of the brain, there is a big vessel going, we call that superior sagittal sinus. And we have to, whatever we are doing, we have to make sure that we are not injuring that vessel that is in the middle of the brain. So for people who are neurosurgeons, they know that there are methods of doing that. We have a drill, we call that perforator. The perforator is a very specific, very refined kind of drill that once when it is on the hard bone, start turning, and it has something like a clutch. When it goes through the bone, when it's on the soft tissue, when there is nothing pushing against it, the clutch makes it stop. So practically it's safe to put it on the skull and make holes there. Now there is a problem. We found out when we start using that, when you put that drill on the superior sagittal sinus, that very large vein that is taking the blood back to the heart here, you have to be either directly on it or far away from it. The danger arises when you're just at the border of that large vein.
Why is it more dangerous to be on the border than on the vein?
And again, we found out the way the bone is, when we have our skull actually sculpts to the form of our vessels inside of our head. Meaning that if you look at the skull from inside, as a matter of fact, I thought I have one here. It has ridges. Actually, get me my skull. I have a human skull. I want to show it to you.
Can you stop share when you show it?
Yeah, let me stop sharing. So this is actually human. Oh, I have to take my background out. So otherwise my thing
And behind it, you don't need, if you do it like that.
like this, it doesn't really come out. So if you see here, there are ridges. You don't see it very well, but there are ridges, meaning some areas of the bone are thicker than the other. Where we have a vessel in the brain, the brain becomes thinner where the vessel is, and around that vessel becomes thicker. Okay? Do you remember this special drill? When it hits the soft tissue, it stops. Now imagine if you're just at the edge of that vessel, one side of the drill hitting the hard bone, but the other side it's in the soft tissue. What that means, yeah, meaning that the drill doesn't stop because one side still hitting the hard bone, but the other side is already through the skull and it's on the soft tissue. Now, if you're exactly where the vessel is, it is smooth, meaning it goes through and it goes on all sides, the drill punches through. When you're outside of the vessel as well, the bone is smoother, but the danger arises is when you go in a place that the thickness of the skull is not the same. And that is always at the edge of the big vessels.
Okay.
So in this case, and what we do, once we put the holes in the skull, then there is another, actually, what we call side cutter. It has like a foot pedal. The foot goes under the skull, and then there's a side cutter. It turns like a drill, but it cuts the sideways, and then we literally can run it and open a window inside of the skull. And once we remove that, and I'm going to try to find actually a picture of it. Long time ago, we used very many other stuff, but the part that I told you that when it goes to the skull and stops, it looked like that. It's a two-step drill. When this pushes on a hard surface, it keeps turning, but when this releases, meaning that it's pushed against the soft tissue, the clutch inside releases and it stops drilling. This is how it looked like. Now, after that, through that hole, we put something that looked like that. Literally, the tip of it goes under the skull, and this drill goes through, and it literally cuts sideways. And that is the modern way of opening the skull. And it doesn't really actually take long to open the skull. That's really surprising for people who don't know that, how fast you can open the skull. So once we open the skull, and obviously I'm going to actually see brain anatomy, brain midline view. So this is actually then what you see. That vessel that we talked about is all the way up here. This is the side view, midline side view of the skull, of the brain. Then on between two hemispheres, right up here, that big vein that we talked about, superior sagittal sinus, is there. And here you see that there, here in the MRI. That is that vein, that big vessel we talked about. And right in the midline, there is that falx. So this is, again, that vessel, and this green here is the falx. And that is the structure that in this patient is thickened, that we have to find out what's going on. So coming back to, okay, we have opened the skull here, and we make it literally like open up the membrane over the brain, And then we will see the brain in this window. And then when we continue past that big vessel, that is exactly where this structure is that is thickened. So, and we took a piece of it out. You can safely do that. And this is what we saw under the microscope. The structure that you see like a round, they're called granulomas, meaning a concentric kind of accumulation of cells. And these cells, obviously not, we know how normal brain or normal tissue in that area look like. So, and we know that these granulomas are actually not part of a usual brain pathology. And when we go farther in, we see these so-called big cells. Unsurprisingly, we call them giant cell. And old-timer who knew nothing about that, they called them giant cell granuloma. And once we know this, we have these giant cell granulomas. This is a typical characteristic for a condition that we call sarcoidosis. Now, sarcoidosis is that disease that I was talking about that for a long time was a magical disease that nobody knew about. Nobody knew what it is, nobody knew why we have, but we knew that people who have that, they have this granulomas, the accumulation of tissue that are scattered all through our body. In many places, it would take a long time before they cause problems. As a matter of fact, the most places that they accumulate is not in our brain, is in our lung. But it can as well accumulate in our many different tissues. In the brain, typically, when they grow, they can irritate the surrounding tissue, and that's where the seizure comes from. In the lung, it take much longer before they're symptomatic, but practically they prevent the normal function of the lung. So these people have pulmonary issue, problem with breathing or exchanging gas and so on. And again, for a long time, we put these symptoms together. An accumulation of symptoms and condition is called the syndrome. And we had all these syndromes that they appear to us in a certain way. We didn't know what it is, and we could just manage the symptoms. Like in this patient, we managed the symptom of seizure with anti-seizure medication. Or in somebody who has granulomas in the lung, we would give them oxygen or other method to help them more their respiratory. So we couldn't really treat their condition. We could just treat their symptoms. Now, obviously, after the surgery, this patient did really well, but it comes back to what would be the differential diagnosis, and this is what it is: a case presentation about Falk's tumor or Falk's mass, and always for us is the first question: what are the things that can make the Falk's or that membrane over the brain in that location become really thick? And this is we call that differential diagnosis, all the things that can cause that. And then we have our statistic. We know what's more common than the other. Obviously, postoperative, that can get bigger, but this patient wasn't postoperative. Infectious meningitis can make the dura or those membranes thicker, but this patient did not have other sign of infection. Like there are certain things that when we have infection, they become much higher in our brain. Those things are like, we call them infection parameter, white counts, white blood cell counts, and like C-reactive protein or sedimentation rate. None of that. Well, sedimentation rate was a little high, but again, the other parameter of the infection wasn't high in this patient. Now, obviously, hematoma on MPoma, hematoma is when the blood is there. MPoma is when the purulent or literally pus is in that location. And as you see, sarcoidosis is one of our differential diagnoses. this is another kind of immune kind of tumor that as well can accumulate in the dura. And there are some other obscure disease that even more rare. Now, dural sinus thrombosis, meaning that the same way that you have a deep vein thrombosis in your leg, those veins in the brain can get obstructed with thrombosis. That's actually a rare situation in the brain because most of the people with that dural sinus thrombosis, they have problem to get rid of the blood in the brain. The intracranial pressure goes up and they die. So it's not a very common situation. And then as well, you see some other the blood cancers and so on that can cause that. Okay, so and there are obviously some other differential diagnosis as well available. Practically in this patient, the reason that patient had this thickening and seizure is sarcoidosis. And I was practically looking up in Wikipedia. If somebody's interested, you can go and look up what sarcoidosis actually is. It is in a category of immune disease, that on immune and autoimmune disease, where these are immune cells that literally accumulate, and they don't behave as the way they should behave. Instead of that, they accumulate in certain places, and by accumulating in certain places, they impair the function of whatever tissue or organ they are in. They can be in lung, they can be in even your heart, in the brain, and so on. And this is a practically inflammatory reaction. And for a long time, all we could do, we could immune suppress, they practically reduced our immune system action to reduce the number of these granulomas that are produced. And as you see here, it can go in almost any tissue that you have, even in your eyes and the gastrointestinal system and so on, even in your bones. And you see, you saw so many things in Wikipedia about all the places it going on, but then very little about the genetic of it, because truly it is we are just about to understand what this is and how to treat that. Now, if you remember, we talked about those giant cells. This is the histologic correlation of that. Once we see that this giant cell granuloma, this is very typical for sarcoidosis. And I'm expecting that in the next 10, 15 years, not only that we are able to understand the true genetic aspect of this, but as well be able to modify our cells in our body with method like CRISPs, where we can go and edit a gene in a living cell, that we can start truly treating these very severe obscure diseases, and sarcoidosis is obviously just one of them. And as you see here, it seems that still immune suppression is the mainstay of the treatment. Now, I'm hoping again that in the next 10 to 15 years, our understanding of not only sarcoidosis but many of these diseases comes to a point that we can truly understand, diagnose, and treat them. And you would be surprised that how many, how often in your environment you hear from people just don't feel well, and nobody can tell what it is. Nobody can really diagnose. They go from doctor to doctor, and there are so many diseases that are based on certain cells not functioning as they should, based on our genetic information, based on or combination of genetic situation. And I'm really hopeful that in the next 10 to 15 years, we are able to understand them so much better, not only because we can now sequence people's genes, but this is become a routine, it becomes easier. And more importantly, with the AI, this has a huge impact because you get a genetic information of a person. It is like having whole library, literally your whole library with 4 letters. No human can really make sense of it.
Yeah, it'll be really interesting to see what AI can do for medicine in the next 10 to 50 years.
Yeah, I think the ability of AI is to go read all those 4 letters, A, C, G, T, and understand that certain combination, how they correlate with certain symptoms and diseases, and literally fish out. Now, until now, everything we know about the genetic, I would say probably 99% is that we see one gene is not right, and then that leads to one disease. Those we understand. But I can tell you, based on how nature works, is that probably for, like, there's a disease called thalassemia, or there is a diabetes type 1, or something that just one gene is different, and that leads to one disease. But I can tell you that probably there are hundreds more in comparison diseases that is not just one gene is wrong and lead to some other problem, but the combination of gene, that's like a cascade. One gene, 10 genes are a little different. Each any single of them or 5 of them wouldn't really lead to a disease, but because all 10 of them are a little different, the accumulation of them, how they interact with each other, make people sick. We are at the verge of understanding that, and I think that is really exciting time with the AI and our ability to sequence genes to be able to help people we couldn't even imagine to help even 10, 20 years ago. So I'm going to stop here. This was a short case presentation, but this is I'm happy that I could show not only sarcoidosis and talk about that and its effect on the brain, but a series of the disease that are based on our immune system, and as well, I think that what's important about it, that we can be hopeful that in the next 10 to 20 years we will have some answers regarding many diseases. So I want to conclude actually here. Amanda, do you have any questions from what you heard here?
No.
Okay, then we can actually conclude that, and thank you for joining us. And hopefully next time we will address as well some other more interesting disease.